So it looks like we still have some people logging in, so I'll give another minute or two just for them to log in. All right, if it's okay with the presenters, I'm going to go ahead and open it up. So I just wanted to quickly welcome everyone to this community forum, moving towards a racially just and equitable health research enterprise. This forum is brought to you by the Massachusetts CTSA Community Engagement Collaborative, which is made up of community engagement programs from the BU, BMC, CTSI, UMass Medical School, and Harvard Catalyst, along with us, Tufts. So today we'll be hearing from a panel of presenters, followed by a moderated discussion. So during the presentation, please remain on mute and direct your questions to the chat box. And I will now introduce you to today's moderator, Christine Sinclair, who is a project manager with Tufts CTSI's Integrating Underrepresented Populations in Research program.
Thanks, Maggie. So welcome everyone again to our event today. I want to give a little bit of background before we introduce our presenters on this particular topic. So this actually came out of a big program that Tufts University hosted, which was called a Day of Reflection, Commitment, and Action for Racial Justice. And in this was sort of like a day event where departments, staff, faculty, students across the Tufts University campuses got together to discuss topics such as where does the institution stand. This actually was done on June 19th of this year, which is what we call Juneteenth, which is a commemoration of the end of slavery in the United States. There were other topics such as COVID-19, a pandemic within a pandemic, and really talking about the intersection between COVID-19 and systemic justice, or systemic racism, excuse me, and then racial injustice, structural racism, and health inequities. The veterinary school got together, as well as the engineering school, to talk about racial inequities, and then members of the Tufts University School of Dental Medicine and other parts of the community got together to share their stories and reflections on personal experiences of being Black in the institution. So we bring this presentation to you today to continue the conversation around racial inequity. What are some of the things that are happening with COVID-19, and what can we do so that we can stay on top of really addressing these issues. Next slide. So our presentations today will focus on identifying how racism operates in research. So structures, the who, the what, the when, and where of decision-making, some of the policies, the written how, the practices and the norms, the unwritten how, and then the values, and asking the question why. Next slide. We'll also be exploring some of the pathways to a more racially just and equitable research practice by examining systemic and structural racism that's related to the lack of integration of underrepresented populations in research, prioritization of research interests and resources, a diverse workforce development, and then recognition of racial hierarchies. And one of the things I want to mention here too is, right, this is sort of like in a cyclical pattern, but I can imagine that we could draw arrows across this circle, that one of all of these things interact with each other in different ways. And so next slide, the question is now, how will research address the current public health crisis? What are we going to do, particularly in the environment we're in right now with COVID-19 and a lot of violence happening around the world, particularly in communities of color or against communities of color? What some of the conversations that we've talked about recently this year are, why is it that communities of color, people of color, Black people are dying at higher rates or being hospitalized more with COVID-19 than any other group of people? What do we do with the resources in the hospital if we run short? Do we give it to someone who already has underlying chronic conditions? So these are all of the questions that we have to ask ourselves in this current public health crisis, and then also talking about systemic racism as a public health crisis as well. So I will introduce our first presenter. Our hope today is that, again, we will continue this conversation, that it will be a reminder, something that needs to stay on our mind and considerations when we're conducting research or in wanting to engage groups of people in research, and not just in research, but through the research enterprise and the institutions that we work in. So our first presenter today is Robert Sege, who is a professor of medicine at Tufts University School of Medicine, where he directs a new center for community engaged medicine. Dr. Sege is nationally known for his research on effective health systems approaches that directly address social determinants of health. He is a senior fellow at the Center for the Study of Social Policy in Washington and serves on the boards of the Massachusetts Children's Trust and Prevent Child Abuse America. He has served on the American Academy of Pediatrics Committee on Child Abuse and Neglect and on its Committee on Injury, Violence, and Poisoning Prevention. He is a graduate of Yale College and received his PhD in biology from MIT and his MD from Harvard Medical School. Bob lives in the Boston area where he and his wife, Karen, have raised 3 young adult children. He'll be talking today on authentic engagement of non-researchers in team science.
Thank you so much, Christine. And it's really a pleasure to be here and to be able to talk to community members from the 4 CTSIs in Eastern Massachusetts about some of the issues involving systemic racism in clinical research. On the next slide, I want to show you what the real problem is. And that is that we continue to have really large racial disparities in death rates. Currently, a Black infant born in the United States can expect to live 3 or 4 years shorter than a white infant born in the United States. And although the gap has closed a little bit, it's still rather remarkable. And in more recent years, we've begun to see a leveling off of the death rate, which has only exacerbated the difference between Black Americans and white Americans. So from a public health point of view, the top line is there's something wrong that we need to address. On the next slide, the other thing I want to do is to sort of set up what we're talking about, is to talk about what is racism. And this is from Kamara Jones, who is our speaker at the Breaking the Silence event in March, and is past president of the American Public Health Association. And what she says racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. I think it's really important to keep this in mind because we're going to be talking about racist outcomes. They don't necessarily imply or require that the people involved in the systems are themselves hold racist beliefs. Next slide. So earlier in January, this Tufts CTSI had a dialogue about racial disparity in diabetes. And if you look at this, the highest rates of diabetes in the United States are among American Indians, Latinos and Latinas, and Black Americans. And you can see that the burden, that 7% of white Americans suffer from diabetes compared to almost 13% of Black Americans. There are many risk factors for diabetes, and we don't have time to go into all of them, but many of them appear to be the result of racism and chronic stress. Next slide. But look at this. This is the difference. We saw before that Black Americans are more likely to suffer from diabetes. But if you look at research subjects, 63% of the US population in the middle line are white Americans. There are 51% of Americans living with diabetes, that's the disease burden, but there's 71% of diabetes research participants. So clearly there's a mismatch between the burden of disease and the people who are participating in research aimed at curing or at least treating the condition. Next slide. This gets even more dramatic if you look at diseases that affect people of color disproportionately. And what this slide shows, in the left-hand column are expenditures for individuals with research expenditures for individuals with sickle cell disease compared to expenditures for research for people with cystic fibrosis. Sickle cell disease is the most common single gene genetic disease in the United States. And it's approximately 10 times more common than cystic fibrosis, the most common single gene genetic disease among Caucasian Americans. So if you look, NIH funding per person affected is over 3 times higher for cystic fibrosis than for sickle cell disease. The total funding per person affected, and that includes NIH plus private expenditures, the second line that's highlighted in yellow, is over 10 times higher, $10,592 per person with cystic fibrosis compared to $943 or less than $1,000 per person with sickle cell disease. And if you look at the bottom, you can see that there are more drugs, more patents, more clinical trials for cystic fibrosis, and many more papers than there are for sickle cell disease. So we have clearly is a mismatch between disease burden and research expenditures. The next slide shows one of the reasons why this happens. Next slide. One of the reasons why this happens is that there are very few Black Americans at the principal investigator or senior level in NIH-funded research. As you can see on the right, the olive green pie slice, 1.1% of NIH-funded principal investigators are Black or African American compared to 12.6% of the US population. And I think this really matters because when you talk with scientists and you say, why did you choose to study the particular problem you chose to study? It's very common to hear a story about a friend, a relative, someone they admired, someone they knew who suffered from that disease. And the scientist had an aha moment where their skills or insight or knowledge might be amenable to approaching that disease. Completely human. Nothing wrong with that, unless you have a system where very few Black or African Americans are making those decisions about what to study. Next slide. So, you know, we think about racism and it may like someone standing on a soapbox talking about some reason or talking about racism, or, and I think that a big driver in science is that family ties, love, that people, scientists are people too, and they want to study diseases that have meaning to them. Next slide. Next slide. Oh, there you go. So what we have, why does this happen? If we look at data mostly from the National Academy of Sciences, there are about as many roughly proportional numbers of young people who enter college interested in science, wanting to major in science, whether they're black or white, and they're roughly proportional to the population. And then this diminishes dramatically when they finish as a major and go to graduate school. And then graduate students who get a doctoral degree and finish, and then those who end up becoming researchers. And so what you can see is that freshmen intending to major in biological and agricultural sciences, black students are washed out more frequently than white students. And those of us who are scientists remember, the first thing that happens is you have to take your introductory biology or chemistry courses in freshman year. Students who come with inadequate high school preparation simply won't make it at that point. And this is illustrated better on the next slide, which is the funnel of how people become scientists. This is developed by NIH. So of course the goal is to become an NIH-funded investigator. And you can see many undergraduates are interested in science. Some of them go on to graduate school. Some of them finish graduate school, go on to postdoctoral fellowships. Some of those end up becoming early stage investigators, and then they get tenure, and then some people get R01s. And what I've shown with the arrows is where there's a big leakage in the pipeline to create scientists for Black Americans, and those tend to be at the undergraduate and early graduate stage. So this is a real problem, and we've done some work. And when I was at Health Resources in Action, we worked with CTSA partner MIT and set up a program to train high school students from Boston interested in science in basic lab skills and give them exposure to science and the opportunity for internships. So they would enter college with a really good preparation in lab science. This is one approach to it. The next slide shows that, going back to Christine's diagram, there's not a diverse diverse workforce in science, which leads naturally to a prioritization of research interests that tends to not prioritize diseases that disproportionately affect people of color, which leads to underrepresentation in research. And the racial hierarchies that go into who gets a good high school preparation clearly plays into this. Next slide. So I'm going to just finish now with a few questions. How can we better prepare interested minority high school students? How can we support college students with less high school science experience? For example, MIT has a boot camp for students who come from high schools that didn't have laboratories, so that they can have an intense summer program to learn laboratory science. How do we develop multiple entries to research careers? The Tufts CTSA, in collaboration with Urban College, is developing a program to train community members to become research coordinators so they can join research teams without waiting for a PhD. And I think all of these things may help improve research engagement by underrepresented people when they see individuals from their community who are part of the research. But I think that we need to talk about something a little bit deeper. When you looked at the graph of how long it takes to become an R01, if we are successful in having every college student who's interested in science, every Black student who's interested in science become a scientist, it would still take about 30 years before they're in decision-making capacity. So we need to think about structural changes in how we direct the clinical research agenda. Currently, NIH chooses projects based on scientific review through the peer review sections, and they choose the most meritorious science. And it's possible to set up another system where other people choose the overall buckets, and the scientific peer reviewers choose among the scientists who are interested in topics of interest to public health, who have the most meritorious applications. So I'm hoping for a vigorous discussion of how we got to be where we are, but really specifically of how we get out of this so that we no longer have systemic racism in clinical research. So thanks, and I'm looking forward to our discussion.
Thank you so much, Bob. So our next presenter is Dr. Linda Hudson. Linda Hudson is an assistant professor in the Department of Public Health and Community Medicine at Tufts School of Medicine, and has been trained as a public health educator and researcher with over 20 years of experience in community program development, implementation, and evaluation. Her work is focused specifically on vulnerable populations, including low income and communities of color, with an emphasis on primary and secondary prevention of chronic diseases. Her recent research endeavors have included a collaboration on a funded qualitative study designed to develop a curriculum to address prevention of cardiovascular disease risk among African American women, as well as a co-investigator on a pilot study to assess a novel approach to influence cardiovascular risk among Black and African American women using principles of civic engagement. At the core of her work are the principles and practices of effective health communication, community engaged planning and research processes, and addressing social determinants of health behavior and health outcomes. She'll be talking to us today about authentic engagement, again, of non-researchers in team science.
Thank you, Christine. And good afternoon to everyone. It's so nice to know, as I look at the numbers, that there's such a large interest. Quickly, my focus, as you read from my background, has always been on community engagement, community-based programming, and interfacing with those who are most impacted. And so one of the things I think about is that the community engagement aspect of the research spectrum is a tale of two cities. It is the jewel in terms of being able to impact our particular research interests and focus, but it's also a part of the research process or a part of the research enterprise that does not always get its due, does not always get all of the funding that it needs to get. And much like my colleague Bob just mentioned, when you think about who gets the research funds and the types of research that's being conducted, the issues that impacted populations and populations of color, as we look at the spectrum and the hierarchy, are not always at the top of the totem pole. And so we need to think about how the community engagement strategies can be used as a mobilization process. One of the things that I want to always remind us about is that when we're thinking about our partnerships and our collaborations, that we are centering our focus on those who are most impacted by the issues we are concerned with. And I think for all of you out there, I don't need to remind you of what the data are looking like in terms of prevalence and incidence and outcomes. And particularly in this pandemic environment of COVID-19, if there were any concerns or any misgivings we had about the influence of racial hierarchies and hierarchies of income on one's health outcome, I would think that all of that has been wiped away by how we've seen COVID-19 has influenced and impacted communities of color and Black and Indigenous peoples of color. One of the things I always like to ensure that as we're thinking about how are we going to intervene is the utilization of community engagement as a key process of bringing the lived and authentic voice into the research paradigm. What you see in front of you is a slide that summarizes to some degree key principles that many of you are probably living right now in terms of your relationships with academic institutions, your relationships and partnerships with our CTSAs and CTSIs. But I always like to reiterate the importance and value, because the voice will get left behind amidst the biomedical models that we tend to hear about in terms of outcomes. Clearly, we're all understanding of the social, political, and economic determinants of health, but unless that is brought to the forefront in terms of the research that we're doing, the translation is impacted and people's ability to be able to benefit from research specific to their impacted situations decreases. So I wanted to remind us that as we're doing our community engaged research, that partnerships and centering our partnerships around those who are most impacted means that there ought to be a way to jointly establish the scope of engagement. I know many of you may be involved with your CTSIs or other organizations, and there's always questions of data gathering and the focus of the data gathering and the hypotheses testing and what problem are we trying to solve, and can we get the funding to be able to solve that problem. But we begin first with engaging the community around defining exactly what that scope is going to be and coming to some agreement on how we can do that jointly and in partnership. Anyone who's heard me in any conversation I've had knows how much I respect and support the lived experience. And so when we come to the table, we have the academic experience, we have the epidemiological experience, we have the expertise that we can bring to the table. But most importantly is the lived experience, the perspective, the historical understanding of the environment in which people find themselves that ought to be able to define the kinds of research that we're doing. The second piece is strong partnerships based on mutual understanding, and actually it should say mutual understanding, respect, and transparency. And so as we think about partnerships, and I remind us of these principles because I'm hoping that those of us who are community members are really thinking, well, if this is an expectation from one of the premier funders, the National Institutes of Health, and these are principles that they are in fact expecting that those of us who are doing research are holding some accountability for, then those of you who are in the community ought to know that you can step up to the research enterprise and say, well, I understand these are, some of the basic principles that one needs to be engaged in, and so I'd like to hear a little bit more about how we are doing these things. But being based on mutual understanding and respect and taking the time and interest in building trust, taking the time and the resources in engaging populations where they are, and that means where they are in terms of their history, the socialization processes they've been through, the culture, the language, all of that is a part of this process of mutual understanding and respect. And in this age, as we're talking about COVID-19, as we're talking about anti-racism and anti-racist training, then understanding the historical legacy of how people feel about research is absolutely at the cornerstone of the work that we're doing. I don't need to remind people about Tuskegee. We're not going to go into a lot of detail on that because most of us have some understanding as to how the U.S. Public Health Service commissioned work that was being done that actually set us up for our principles in terms of what we do in terms of human subject research because of the degrading manner and the lack of integrity that was brought upon whole communities of men. We also could take a look at, go back further in the history as we look at the three enslaved women who were worked on by Dr. Robert Sims, who was heralded as the father of OBGYN, and the kinds of terrific, horrible experiences that they had. So we don't have to go back that far, but what we do have to understand as researchers is that we have a collective memory, and that there is a memory that even though many generations may not know all the details, they know how they felt as a result of hearing about these kinds of stories. So ensuring that we have equitable power. Yes, thank you, Lucy, Betsy, and Arnaka. Thank you, Dr. Ndidi, with the name of the enslaved women who I mentioned earlier, and many of you can look it up in terms of the work that's taking place. The other principle that I want to make sure that we get across is equitable power and responsibility to encourage diverse perspectives. So and when you are engaged in or asked to be engaged in research endeavors, then you ought to be able to have discussions around what happens with the data, how do I get information regarding what's going to happen with my participation in that process. And when we think about the fact that so many of the processes that dictate some of the treatment plans, some of the prevention activities that we're engaged in, do not have underrepresented populations involved in them, then we need to think about how can we equalize the playing field. What is it that we need to be doing to ensure that those persons who are not representative could be represented in this process? The next to the last thing is investing in capacity building. And one of the things that we're thinking about in terms of capacity building is where are we investing our resources, our physical resources, our financial resources to ensure that that lived voice has as much power in terms of determining the problem posing, the problem solving, and the implementation processes. And last is the effective dissemination of information, which I touched on earlier. That says that we have a core value of giving back to those who have participated with us as partners to be able to assure that we disseminate information in a way that is easy, that is relatable, that makes sense, and that allows for a dialogue. One other thing I would mention as we're looking at this COVID-19 environment is that similar to what we're doing right now, we're going to have to make sure that we find ways of continuing the engagement process. We're not going out to organizations and halls right now. We're going to maintain social distancing, but we don't want to lose the motivation and the energy that is there. So we're pleased to know that so many of you are using this mechanism, but we as researchers have to be innovative and think about how we can reach out to those populations that have been underrepresented in the past to engage them in this process. How we can use this in terms of mobilizing communities and thinking about how we can, in fact, provide information and education on a continuous basis. So my point here is, as my colleague talked about our difficulties in getting and ensuring that we have representative researchers involved in the process, the other end of the process enterprise is how we can engage and support and bring community voices even louder and with more strength. So one thing I would say to you is there's a lot of research taking place right now around COVID-19 in the greater Boston area. We are a mecca of medical care. We are a mecca of schools of public health. And so you may want to check in with your local CTSIs to find out what kind of work is taking place and how you can participate in those kinds of activities. So that, I'm going to bring it to closure. We can do some more discussing during the Q&A, but I just want to assure that we are all on board with understanding that this aspect of the research enterprise is as important as the bench science aspect of the research enterprise. Thank you.
Thank you, Linda. Our next presenter is Dr. Sarah Folta, who's an associate professor at the Friedman School of Nutrition Science and Policy at Tufts University. Her research interests focus on public health nutrition, or the utilization of community-based strategies for improving dietary intake, physical activity, and body composition. She has particular expertise in behavioral psychology, communications, and qualitative methods. A major line of her research involves community-based interventions to improve heart health among women, with a current focus on African-American women. She serves as Director of Integrating Underrepresented Populations in Research for the Tufts CTSA. And also, Dr. Folta received her BA in Biology from Middlebury College, Phi Beta Kappa highest honors, and MS in Cell and Molecular Biology for the University of Vermont, and a PhD in Nutrition from Tufts University.
Thank you, Christine. So I'm going to very much build on what Dr. Hudson just talked about in terms of engaging community members in the research, and I'm going to focus on researchers, but I want to note that we're owning the problem, and we do have a problem in how we engage. And I'm going to talk about strategies we're promoting among researchers, and it boils down to what we think you should expect from us in a good engagement process. So, as you saw, there's underrepresentation as scientists from Black, Indigenous, and people of color in academia. And we need to start the process of engagement with communities by acknowledging that in academia, we have essentially a hostile environment for BIPOC persons. And we need to shed our, especially in the Northeast, our white liberal blinders and see the academy for what it is, which is an institution with racism built in at every level. And that's the lens through which we can start more genuinely engaging with stakeholders. And So in terms of strategies, we believe that genuine engagement with community stakeholders starts with just how we introduce ourselves. And as academics and clinicians, we typically do this by listing our positions after our name. And for us, this helps orient us within our very hierarchical system. So an assistant professor knows how to react when introduced to a dean, or a research coordinator knows the unwritten rules on how to act around anyone with an advanced degree. And we're so immersed in this system and culture that it's automatic and unnoticed for us. When we introduce ourselves with our titles, whether that's doctor, professor, director, manager, coordinator, and so forth, it has the effect potentially of reigniting anger and frustration regarding differential access to resources. It privileges knowledge gained through higher education and negates and devalues other forms of knowledge that may have been developed outside of the traditional educational system. So an alternative is to approach introductions as an invitation for people to begin to tell their story in a way that builds connections, trust, relationship, and context. And we use this approach with our Integrating Underrepresented Populations in Research Steering Committee. And this is comprised of both academics and community members. And we started by asking everyone to state their name and to talk about a person who had inspired them to do the work that they do. Everyone was given a minute to think this through. And what happened is that participants spoke about family members, mentors, early teachers, and the lasting impact these people had made on their lives. And it allowed us to connect on shared values around equity, justice, and serving others. We try to encourage research teams to take this approach as a way to acknowledge that all participants are both seekers of truth and members of communities. Beyond introductions, the structure of interactions can help keep the focus of attention closer to the wealth of knowledge, skills, and abilities that stakeholders bring to the scientific discourse. And to meaningfully engage, it's important for research teams to acknowledge that they're placing value on certain forms of knowledge. And the point is not that stakeholders are lacking in these forms, but that other forms that these groups and stakeholders have other forms of knowledge that they have acquired that are often less valued. So as researchers, we tend to place our faith in the power of data, that which can be obtained through a systematic process of observation and experimentation, and we seriously undervalue other types of knowledge, including, as Linda mentioned, lived experiences. Researchers often do acknowledge the intellectual, social, and cross-cultural skills that community members attain through the ability to communicate in more than one language. But there are pitfalls with this. What often happens when we engage with people who have a different language or two languages is that the research team overutilizes those community members as cultural ambassadors, expecting them to be accurate spokespersons for an entire culture. And even when the stated purpose of the participation is more broad, community members with more than one language often become relegated to the translator role. So we need to avoid these pitfalls, and research team members can structure interactions such that multiple forms of communication are valued. So for example, in addition to discussions about data, team members can be encouraged to bring examples of art, music, photography, or engage in storytelling related to the issue at hand, and to really value those other forms of communication. Within underrepresented communities, there's often a strong sense of community history and commitment to the community well-being. And again, Linda mentioned this in terms of dissemination. Researchers can value these strengths by contributing to them, by providing information and resources to the community team members in ways that will facilitate their sharing of those resources within their communities. So the dissemination of findings, for example. And this means that researchers need to be translating findings into accessible formats that can be disseminated through stakeholder networks so that they can be easily understood and used in those settings. Researchers also need to both recognize the difficulty that stakeholders may have in navigating through racially hostile university and hospital systems, and to honor the skills they've developed in effectively doing so. So a simple but important action that research teams can and should take in this regard is to hold a meaningful proportion of meetings in community settings. Don't always make stakeholders come to them, but go out and meet stakeholders in the communities. So researchers can value knowledge and skills fostered through oppositional behavior that challenges inequality as well. And these skills can be valued through reconciliation activities, and there are types of activities that research teams can organize and participate in. And at Tufts, we have a series called Breaking the Silence, and that has brought expertise and fostered conversations on topics that affect our community, including the impact of racism and weight bias on health and patient care. So to wrap up, authentic engagement with community stakeholders is challenging, and researchers need to realize that. CTSAs are ready and have many resources that can help foster that process and make it more inclusive and equitable.
Okay, thank you so much, Sarah. So thank you to our presenters today. So we are going to go right into our discussion for the day. We have a couple of questions for us to reflect on, which are which research questions are funded, who is doing the research, on whom is the research being done, who receives and interprets the results, and what actions follow, and how can we transform research with consideration for past and present experiences of racism and marginalization towards an equitable, healthy, and safe future for everyone. And so please feel free to begin putting your questions into the chat box, and I'll do my best to keep up with those questions, and we'll ask our panelists those questions. Some agreements for our conversation today. Please keep in mind that it's great for you to use I statements. So use I statements, not speaking for the group, a group of people, but instead speaking from your perspective and experience. And keeping in mind that your perspective and experience may not be shared by all. We will honor what people have to say, even when it causes discomfort. We will assume good intentions while also owning that good intentions sometimes have a negative impact. We will acknowledge white privilege within this space and step up and step back as necessary. We will recognize that through these times are very difficult for everyone, that the Black community is experiencing the greatest burden, distress, and stress. For this reason, they will be uplifted and centered at this space. Come to understand where people are coming from by asking clarifying questions of curiosity, being mindful of the space you have or have not taken up in the conversation, and encourage others to join in. And discouragement should be voiced with empathy for the beliefs and values of others. Before we get to the questions in the chat, I actually wrote down a few questions that came to mind as I was listening to the presentations, and I'll just read them off for each of the panelists. My question for you, Bob, I'll read them all at once and then feel free to jump in to answer. But you mentioned about underrepresentation of persons of color in leadership positions. And then you also talked about underrepresentation of students in the sciences, or focusing their studies in the sciences. And you gave an example of why some students may not continue focusing in the sciences, and that was they're being discouraged in focusing in the sciences. But I wonder, what would be the reason why there aren't any persons of, lots of leadership positions for persons of color? Is it because they don't want to be in those positions? Or what would be a reason why you wouldn't see people of color in leadership positions, or enough people of color in leadership positions? And my question for Linda is, you talked a lot about the principles, the guiding principles for investigators and research staff to engage stakeholders in research. And all of the principles they seem really like really great principles and things for us to consider. But I couldn't help but to notice that when Bob was talking about funding from the NIH, that there's a huge gap between what types of research is being funded and what the NIH is funding for certain groups or certain types of research. But then this body, NIH, who is also giving grants, also has these principles for engaging stakeholders. It seems like there's a disconnect between the NIH recommendations and then what NIH is actually funding. So what do we do about that? What does that even mean? And what do we do about that? And then for Sarah, you mentioned that the academic environment can be a hostile environment for students of color. Is there anyone else in the academic environment that academia can be hostile towards? And then what do you mean by hostile? So I'll open it up to anyone.
Do you want us to go in order?
Sure, that'll work.
So I think that Christine, you asked a really, really good question. And one of the issues is that Black students enter college interested in science at about the same rate as white students enter college interested in science. But because many Black students attend schools, public schools, that have no labs or not very good science preparation, they get discouraged among other reasons right at the beginning because they struggle with those freshman year science courses. And science builds on itself, so it's pretty hard to recover from that. And so there are many other problems with implicit bias. There's a whole literature about other things that happen. I want to point out that because the second part of your question, though, is about leadership positions. And my view is that scientific review, which drives funding, needs to be done by scientists because it's very technical, they understand that. But decisions about what topics get studied and relating our research agenda in the United States to public health burden does not require someone with a PhD and 20 years of experience in the lab to do that. And so I think that we're at a time where if we want to have an anti-racist agenda for establishing research priorities, we need to have a collaboration between scientists and public health people or others who can set priorities based on burden of disease while we work very hard to encourage people to become scientists.
Okay, so I'm going to go ahead and jump in, Christine, with the question that you asked around the disconnect between looking at the lived experience in community engagement as important, and particularly those people who are most impacted, and then the fact that we don't have more research in that direction. I think we are moving in a more positive direction, but I think there is a culture of science that takes a look at what is most important at this time in terms of the investment of resources, what's going to be the most immediate outcome from the investment of resources. And I think we need to have, and this goes back, I mean, this is all interrelated, to having more researchers who are devoted to health equity, health disparity research, but who are also those who are representative of those populations who are so impacted. And we can't wait until we get a collective maximum or effort in terms of moving through that funnel that Bob shared with us, but that right now, those of us who are engaged in that kind of work are going to have to advocate for more funding to be able to assure that we have funding available to work on the issues that we think are important, while at the same time, those who are in the lane of being able to educate more researchers that are Black, Indigenous people of color can be doing that activity, while those of us who are in the research enterprise should really be pushing for more funding in the direction of the community engaged research and those people who are most impacted by the work that we're doing, and also training people who are engaged in the research process, the non-scientists, to be able to raise their voices as well in those funding circles where these kinds of decisions are being made. But you're absolutely right, there is a disconnect.
Thank you. And Sarah, are you still here?
Yes, sorry. I'm actually on vacation in a small hotel room with other people, so it's a little challenging. But I did get your question about the hostile environment. For whom is it hostile, and what do I mean by that? You know, and I can speak only from my own experience, and others may speak from theirs. You know, and I'm not Black, Indigenous, or a person of color. In my own experience as a first generation person to go to college and coming from a disadvantaged background, and you know, and experiencing a lot of you know, what I would say is hostility toward my background, and even the words I use, the language I use, the way I speak, having, you know, the unwritten rules and the hidden curriculum. That was something I experienced and had to really navigate for myself. And so, you know, and I don't want to speak for anyone else, but acknowledging that every aspect of academia is built with a certain type of person in mind, and so it shuts anyone else out. It's like, from, you know, again, from my own experience, it's like you are there to play a game and someone else has set all the rules, and when you try to learn those rules, they change them, or they say those aren't the rules for you, things like that. So that's essentially what I mean by a hostile environment.
Thank you for sharing that. There's one question in the chat box from Chin, and Chin says, what can you do to support people of color after you elevate them to the leadership position in a research institute? And what is the best practice to ensure that you don't just have a token diversity, and how do you foster an inclusive environment? And I can open that up to any one of our panelists to answer, and sort of we know what the issues are, but how do we address them? We've talked a little bit about some of those, but how do we address the hostile environment? How do we, you know, address this issue of making sure that people stay?
Oh boy, I'll take a stab at it, but I'll take a quick stab because I want to hear from my colleagues and maybe other people who are joined us. I think that if you have someone who's from a different background, the team becomes richer, the science becomes better, you get new ideas, it's not stale, and you do that. So I think we need to open ourselves to recruiting people who may come from a different occupational background or different education, and then work with them to learn the skills that they need to do the jobs that they have. And I think Sarah commented that in academia, we place a lot of value on degrees and letters and training. And that's important for some jobs. I don't want a heart surgeon who hasn't gone through a very rigorous training program to operate on hearts. But at the same token, we need to look carefully at what the jobs are, what skills and competencies you need, and how we can bring people in who come from different pathways and support them with the education and support they need to succeed. And then I'm hopeful that as we do this, we'll have a self-fulfilling beneficial cycle, because we all realize how much better teams are when we're more diverse.
One of the things I would add to what Bob had to say is, Shanshi, I also saw your second question, your second statement there. That token diversity issue is something that we face in many academic settings and many organizational settings. And to have leadership that does not have authority, power, resources, and funding to be able to make a change in the environment in which they are operating is to some degree tokenism. One of the things I would consider in terms of an inclusive environment is that if you're going to have a leader who has an interest, it's not only the leadership, but what are their interests? Are their interests going to support bringing forward the kinds of issues and concerns that we have around Black and Indigenous peoples of color, about those who have been marginalized? Are we going to have leaders that are going to be talking about oppression and marginalization and research's investment in addressing those issues? So I think the tokenism is about putting people in positions, but not giving them the authority, the power, the resources to perhaps create their own team and to influence the mission and the agenda of the organization that they're in. When you stop at giving people entree into being able to really make a difference in terms of developing that mission and going through a process of assessment as to what's going on in that organization, then it is tokenism to some degree. My opinion, Shenshi.
Thank you. Thank you, Linda. And Sarah, I'll give you a chance if you'd like to say anything else. If not, we have a few more minutes to wrap up.
Yeah, just very quickly, I do agree with what both Bob and Linda said. I think from my perspective, part of fostering an inclusive environment is admitting that we don't have one currently. And I think that is something that, I think it's getting more recognized in the current environment, but I think a lot of times, again, there's an assumption like, oh, we're doing things a certain way, it's open to everybody, and it's really not. And so I think like they say, the first step to addressing a problem is realizing that you have one, and I think coming to that reckoning is an important process.
Agreed. Thank you so much. I want to say thank you again to our presenters for today. It's wonderful to hear your perspective on engaging stakeholders, what the problems are, how to address those problems. Again, for those who are on the call today, we wanted to remind you, if you were in the Zoom meetings a couple weeks ago on Juneteenth, but if you weren't, to really bring it to your mind of the things that we need to think about and the things we have to consider when we want to engage people in research, from the entire research spectrum in academia and beyond. And so we hope that you continue this conversation, that you will create other opportunities to talk about these things and really to tackle these issues. So I will pass it back over to Maggie and we'll close out for the day. Thank you so much for asking your questions, Chin-Chi, and really grateful that you guys have been on the call.
Thanks, Christine. Just very quickly, if anything you heard today interests you and you want to learn more about community engaged research, please get in touch with your local CTSA community engagement program. We are all happy to work with you. We were supposed to have a minute or two for Christine Choi just to talk about this opportunity at Tufts IRB, but there is an opportunity if you're a community member in Chinatown and you may want to be involved with the Tufts Health Sciences IRB, you can get in touch. And if I realize this contact info is on the slide here, but if you missed it, you can always contact me for it. And then just to plug our next forum to be announced as far as date, but probably sometime next month, it'll be another COVID-19 research community forum. And we'll have some speakers from MIT talking about thermal imaging. So again, thanks everyone. And this will be recorded and shared out with everyone who registered. And of course, you all can feel free to share it with others.
All right, thank you all again so much. Have a great weekend.
You too. Thank you all.
Thank you.
Thank you.